All right. Without further ado, I've talked enough. I will start us off with the presentation for today. I am very excited and very thankful to have Courtney Thaxton here. Thaxton here. I cannot pronounce people's last name today. I'm very sorry. I apologize. Um, Courtney is an associate professor at the genetics department at UNC, the University of North Carolina at Chapel Hill. Courtney is the director of the ClinGen affiliated UNC Biocuration and Coordination Core. She oversees the training and progress and development of clinical domain working groups and expert panel for ClinGen. I think everybody has heard of Courtney and know Courtney and ClinGen, but we were very excited to have you, Courtney, and thank you again for being here. And you should be able to share your screen whenever you're ready.
Great. Well, thank you all for having me. I'm very excited. I know many of you may already know ClinGen. For those of you that don't, hopefully you get a little bit more insight into what we're doing and how we're working with Mondo and other resources when we're trying to represent our work on ClinGen. So really, as Sabrina said, I'm going to go over today some guidance and recommendations that ClinGen has developed for how we define our disease entities and have monogenic disease naming nomenclature, and why this is important. So just for you that may not be familiar with ClinGen, I'll go through quickly. We developed in 2013, so we're going into our 12th year here. And we went with the aim of having to create an authoritative public resource that defines the clinical relevance of genes and variants for use in precision medicine. It was really important coming out of the Human Genome Project. We were getting, hundreds, thousands, tens of thousands, hundreds of thousands, millions of people now, right, that are having their genomes analyzed and looking at how genes may be playing a role in their diseases that are developing. And we were having many different interpretations of variants and genes and whether or not they were actually causative of monogenic disorders is where our focus is. And so really ClinGen came together so that we can be able to understand a little bit better about those genes and their relationships with disease and variants as well. We are NHGRI funded, and we have 3 main grants we call our core grants, and I'm at UNC, one of those core grants, but we certainly have co-funding from other institutes and centers from the NIH for our expert panels. And so really, how do we get this whole resource to come together to be the authoritative resource we think we've now built after 12 years? And our key goals in this are really to aggregate, right? We want to collect, which is what aggregate means, but also to share relevant data we have about genes, genetic variants, and genetic conditions through the development of our infrastructure and standards. We also curate, right? That's the core of what we're doing, what Mondo does, what several other resources do. We evaluate that data using evidence-based frameworks that we've developed in ClinGen and or improved upon by other authoritative sources like the American College of Medical Genetics and Genomics. And we really do this through an expert curation ecosystem. Of course, after we've done all of this, how do we make sure that it gets out to everyone? We need to disseminate that work. So everything that we do is building infrastructure, curation systems, tools, and we create them to make them open access so that we can share all of the evidence that we have across many individuals, as you see on the top, patients, clinicians, laboratories, researchers, interested individuals, anyone. It's all open access, and we do our best to have our standards meet the FAIR principles. We also want to make sure, though, as we're doing all of this, we know that technology is advancing and changing. Our understanding about genes and diseases is changing. And so we always want to be able to come back and have a level of evaluating and improving across all 3 of those main goals. And so these are these processes we start to bring in about recuration and looking at genes and updating them. And so, as I mentioned, we really do this through what we call an expert curation ecosystem. So as it says, we bring together experts in the field in different areas and clinical domains. We call them clinical domain working groups or CDWGs, and they really are those major organ systems throughout the body. But in addition, in that expert panel, we need individuals that are the biocurators. They actually collect that data, they apply the frameworks, and as a group, they begin to discuss and be able to weigh the strength of evidence. And of course, we can't bring together over 120 expert panels without having individuals who are coordinators. And so still genetic professionals, still understanding, but really helping us to keep organized as a group. ClinGen itself then builds those frameworks or improves upon them, as I mentioned. We also provide the training, and we keep building recommendations so that we can have more clarity of our process, but also we can have consistency, which is why we've created that authoritative resource. We are consistent, we are transparent, and so many people appreciate that about the work we do. And of course, to be able to do all this, as I said, we need to build infrastructure. So we have a data platform working group that really works on building interfaces across all our curation activities, databases, tools to help us make sure that we make things not only consistent and transparent, but also more efficient for us to get those curations out to you in a timely manner. And then, of course, we need a website to disseminate all of this knowledge so that anyone can come and use this data as they need. So the main curation activities that we have right now in ClinGen are gene, where we look at gene disease validity, variant, dosage, looking at haploinsufficiency or triplosensitivity. We have actionability, which is really geared towards what do you do when you find a secondary finding of a variant for testing. We have somatic cancer and baseline annotation. But for today, I'm going to really focus around gene disease validity and curation. Maybe because I'm biased because I'm the Gene Curation Working Group Chair, but I also think this sets the stage for a lot of the other activities here. And hopefully by the end of this presentation, you agree. And so on gene disease validity, we really are assessing the strength of evidence that a gene is involved in a monogenic disorder or a single gene disease disorder. We moved from Mendelian because Mendelian implies inheritance, and we know there are several diseases where you have de novo inheritance or even somatic and it's one gene. And what we did in ClinGen is we built this semi-quantitative framework that you can see over here. Not only are we looking at different pieces of evidence, both at the human level and what we call our genetic evidence, looking at segregation, how a variant segregates within families if possible, but we're also looking at experimental evidence as well that can support this evidence. And each one of it has default points that we can give, and it has a range because, again, that strength of evidence, we have to have the ability to have that range of points. And so really, this is important when we think about having this structure and framework defines that criteria that's needed to demonstrate causality, that a gene actually is involved in this disease. And of course, it's organizing and quantifying that different type of evidence and allows us as an expert panel to methodically assign clinical validity classifications. But a key part of this, it's a gene disease relationship. So what's disease, right? And we can say that seems pretty straightforward and simple, but in fact, it's not. And many of us in our world and in clinical genetics and in just medical and the clinical side, we use a lot of different words. So for instance, we use the word phenotype, and people may think phenotype is a disease, and it's used differently across different settings. And so we really need to have an effect in our ClinGen lumping and splitting working group where it started in disease naming advisory committee, that we really needed to provide an understanding of what the word disease meant to us and what phenotype meant in phenotypic features. So just to clarify, when we talk about in ClinGen phenotype, we really are talking about the fact that classically this word meant phenotypic features are observed and measurable differences between organisms, right? So we know that there is some phenotype arising, but we may not know the cause of that phenotype or the etiology. So for us, fundamentally, a disease can be described as a collection of these features, even if the etiology is unknown, right? So that's really where we have phenotype. And that those phenotypic features among individuals with a given disease defines a spectrum of that disease. So we can see there's different severity, different onset potentially. And then we can use the disease itself as a synonym for that phenotypic spectrum. So you can see how it starts to get muddied and why we really appreciated working with Mondo on this. So for simplicity, for ClinGen, we defined monogenic disease. And that for us, it represents a unitary and distinct entity attributable to genetic variation at a single locus, which creates a pathophysiological state for specific phenotypic variation to occur. So simply put, it just means that a single gene is causing the collection of phenotypes. So we have the etiology and we have the phenotypic features in the collection of that disease. And that will become important when we talk about our disease naming strategy later. And you might go, why is this even important? Why do you need to define the gene disease or what the disease is anyways? Just get to curating, right? Except for the fact when you're using a semi-quantitative method, all of the basis of all our curations lies in the relevant data available. So it really is important for us to define the disease, the phenotypes in the spectrum, because that is ultimately going to affect what we include in the score and what we exclude. So that means we're going to really be considering what points we can even consider and begin to score. And that includes clinical reports, case reports, segregation, experimental evidence. The whole range of information that we collect is very dependent on defining that disease. And you can see what happens if we go to split many things. Now, I'm not saying whether these are appropriate splits or not. We've got to go back and evaluate them. But you can see how if we start to define that disease entity differently, we can get to different classifications. And again, you may go, well, why does that matter? Well, when we're thinking about clinical care, it really does matter. Because in fact, ClinGen's gene disease validity classifications were used by the American College of Medical Genetics and Genomics in 2020 to indicate that depending on the strength of evidence and that classification is whether or not you can return results to patients for whether a variant found in that gene is pathogenic, likely path, VUS. So if you get into the limited area, you cannot return anything over a VUS. So ultimately, our classifications are really important when we're thinking about diagnoses and patient care. So hopefully understanding the importance of this work and why being able to define the disease entity is also going to be important. And again, you may go, doesn't matter. But what happens when a curator sees this? Right? We all come across this if we've done curation, whether it's a gene or other things. You have one term, one terminology, it has multiple definitions, and this is no different. Element A is now found to be associated with 11 different phenotypes or possible disease entities. And so we could simply go just curate them all separately. But what if some of these are part of a phenotypic spectrum? What if they all might be representing the same phenotype? They're just called differently. Again, if we start to split, we can really, again, start to affect patient care and in a negative way rather than positive. And in fact, when we go to look at information on OMIM, we can see this is not just an isolated or zebra effect. Oh, it's a very low percentage. It's extremely rare. About 30 to 33% consistently through the time OMIM has been established, we have been able to see that genes are associated with more than one phenotype. And so this isn't just a very small fraction necessarily of genes, and it continues to grow and grow at the same rate. And so it is really important for us to think about in ClinGen and develop guidance for how do we help groups determine the gene disease relationship, what they should include and exclude. And that's that term of our lumping and splitting. Lumping to mean we've said that multiple different phenotypes belong in the same spectrum. So we're going to lump or we're going to merge them together. And split means we actually think that they're separate, but we needed to come up with that guidance. And so what we initially came up with was 4 different criteria that each expert panel needs to weigh to evaluate whether or not these 2 different entities are potentially part of the same phenotypic spectrum and lump, or whether they are part of distinct diseases, and they can be split. And so, of course, we wanted to put assertion as one of them. Obviously, people can assert things in literature, though, and literature is biased. So while we have assertion, it's not our strongest category we want to go by. We're not called clin assertion, we're called ClinGen. And so we really want to look at the genetics. However, it is important to see what has been asserted by different individuals across the publication spectrum. The main one that we really want to push for people to use is molecular mechanism, right? Looking all the way back down to, are you seeing the same variants, the same type of variants? Is it always loss of function versus gain of function versus a dominant negative effect? That's really important when we think about lumping or splitting, especially if not only patient diagnoses depend on this, but their treatment, right? You would not want to treat someone who has a gain of function with inhibitors to different genes. You also wouldn't want to increase the gene if you're doing gene therapy, because that could cause something even worse. So having that molecular mechanism is really important. And in the absence of us knowing, then we might say just lump, because you don't know. There needs to be more data. The other things we want to appreciate is that in the absence of molecular mechanism, which you might say, we all know the mechanism. No, it's usually not clear from the very beginning, and it takes a lot of functional evidence to help support it. So the other thing we can look at is the phenotypic features. Do we see specific features that are developing between individuals? Do we happen to see a correlation that those are different types of variations that are occurring, or within a different domain of that protein? So if we do see that there are some phenotypic differences in the absence of a known molecular mechanistic difference, we can then decide whether we lump or split. And then the last one we want to look at is inheritance pattern. We can have situations where dominant and recessive occur and actually represent a spectrum. We call that semi-dominant. That's a dosage-dependent effect. We also know there's just allelic requirements. When you have recessive disorders, if you have two missense, you may still have retained activity, and that's going to be less severe phenotypes. I don't want to say anything less severe to patients, but if we look on the spectrum of activity, it might have retained activity versus two null alleles where you have complete loss of activity. We may see a spectrum of that. And so these are the things we consider when we look at lumping and splitting and defining those disease entities. And all of them are published in a process we call pre-curation on our website. And so everyone can see what we've decided to lump or split. And that's really important, because what do you do with an example like this? We have MED12 related, or MED12 as a gene. It is at this time associated with 4 different phenotypes. In fact, the Intellectual Disability and Autism Gene Curation Expert Panel in ClinGen decided that 3 were evaluated at the time, because there were only 3. The 4th one has come later from their curation. But those 3 that were presented at the time, they felt actually represented the same spectrum of disease. So they are lumped. But what do you call it? Do we call it Lujan-Free syndrome? Do we call it Lujan-Frie's Opitz-Cavagius syndrome? We're really starting to get a mouthful here. What do we need to do to reflect what this disease entity is accurately? So out of our lumping and splitting process came a lot of other questions that had guidance that needed to be provided. So how should we name monogenic diseases? When should we name it? And some of them, if they have a name, should we consider renaming it? If we're naming new ones, should be consistent with other ones that may already be fine, that we don't want to lump or split, but we still want to maybe update that name? And how do we do that? Who needs to know, right? And how do we communicate those updates and changes? And that really helped solidify a lot of our relationship we had with Mondo. For us, we said, well, Mondo might be the mechanism for change, and they're the ones who may be very well prepared for us to have these changes and represent where we might call something one disease, but someone else still wants to split. And so that's where we worked to develop guidance and a working group so that we can ensure consistency of this approach across expert panels and working groups, right? We didn't want to leave everyone willy-nilly to do whatever they want, because it would look really confusing and it would not be consistent. And so because ClinGen is framework-oriented and evidence-based, we like things to be consistent. And so that's when we developed this disease naming advisory committee. And so you can see we have representatives from ClinGen as well as Mondo and OMIM, and we came together so that we can have an effort to be able to provide guidance for defining, establishing, and naming ClinGen curated monogenic disease entities. And again, this is a way where we don't necessarily expect any of these entities to change their own, but how can we all harmonize together so that we can have a consistent approach and bring it to a place like Mondo that can help represent all of the different preferred names across these entities. And so just to give a brief overview, we drafted guidance, right? We can do that. But we also went out to our expert panels and we asked them to please test this guidance, give us feedback. Is it working? What needs to be changed? What are other considerations? And we did that across gene and variant curation expert panels, but also our actionability and even into dosage. So then we did an update and validated. We did a workshop as well with this, and then we refined some more and released that in 2023, and our paper came out in 2024. And so really that future goal at the time was to develop the implementation of these preferred names in Mondo, and that's what we're really working on now. And I'll tell you about that other group later on, just so we can grow our knowledge base. But again, this whole effort was for us to be able to harmonize our disease naming concepts, make sure that ClinGen can have a name in the game for our representation, because ours really are tied to a curation, right? These other phenotypes we've lumped may want to be split for clinical representation and diagnosis. But when you come to our site to look at what we are curating, you would be able to understand whether there's more information that has been captured in that curation than what you might see on OMIM alone. So this is that example of where we can curate something on ClinGen's website and make sure that there's a representation on Mondo and that we are explicit on OMIM, and that really comes into our pre-curation efforts. And so part of our recommendations, just to tell you, is that gene disease classifications should be oriented toward the monogenic disease entity and not a specific phenotypic feature. We want to also avoid renaming well-established phenotypes unless absolutely necessary. So we do understand renaming may be appropriate and warranted by changes in the field or by invested users, or what you may call stakeholders or patient requests. For an example for that is intellectual disability, right? There was a term for this called mental retardation. Unfortunately, we use it as a pejorative word in our population, and so that no longer was an appropriate usage of that particular disease entity or name, so it moved to intellectual disability. And we also just have to have an appreciation of this image here, that names change with time. And so that is one of the reasons why we chose to work with Mondo, is that they are capturing those synonyms, capturing those changes with time, so that we know that we're talking about the same disease, even if we're looking at a paper from 2025 all the way back to 1998. And also we feel that disease nomenclature should be this dynamic process, as we see there, right? And so use of standard IDs within ClinGen for these disease tracks that provenance and changes with time. So it's why we really want to make sure we're using as many identifiers as possible, knowing those names may change. While it seems bad and we may say we don't want them to change in this process, it's something we're all used to every day. People's names change every day, but we know it's the same person, and that's the same with diseases. And so, as I mentioned, we are using what we want to call a dyadic approach here. And so that strategy explicitly recognizes the etiology or the responsible gene, right, or cause for that disease, a gene in this instance, in addition to a descriptive phenotypic label when we call this a ClinGen curated disease entity. And so that's basically what it's telling you here, is that we know that there's enough of a phenotype that is normal phenotypic spectrum, but when we know that there's altered function based on a gene, we want to be able to indicate that gene name either with an obviously an identifier and in the disease name, but also that phenotype. And so there's two different ways that you can do this. You can do that with the explicit form, in which you are calling out the gene itself and gene-related phenotype or phenotype due to a gene deficiency and so on, or an implicit way where you can use an alphanumeric to indicate that gene. That is much like what OMIM does today. So phenotype 1A, 1A, and you can see pluses and minuses to all of these methods, especially if we're using an alphanumeric. However, it is a way, two different ways for us to convey that there is something that is the causative factor for this disease. And so just looking at a table of all of the possible range of synonyms or ways that we can indicate the same disease with different names of a dyad, this is the table here. But ultimately, the most important part is that we are tracking with the identifiers which ones are all talking about the same disease, because we're agreeing on the fact that this gene is the responsible party for the spectrum of phenotypic features that are arising from variation in that gene. So again, we did say we wanted to make sure groups would minimize changing well-known and widely accepted phenotypic labels. An example of this would be Marfan syndrome, cystic fibrosis, and sickle cell disease. And we asked them to only reconsider naming if there's very strong rationale, such as reducing confusion or correcting major errors. In fact, we have an example of that. So an initial paper describing germline variants in CHEK2 asserted a feature similar to Li-Fraumeni syndrome, and it was thus called Li-Fraumeni syndrome type 2 or number 2. However, with more evidence and more data that came out through the years, they saw that the cancer risk for CHEK2 related variations are now known to be much lower, and the tumor spectrum is distinctly different than that for TP53 related Li-Fraumeni syndrome. So TP53 was the first Li-Fraumeni. So in fact, this is something where they renamed it as CHEK2 related cancer predisposition syndrome and have a new Mondo name for this instead of Li-Fraumeni syndrome type 2. And again, just to reduce any confusion with TP53 related Li-Fraumeni syndrome. We also encourage groups to engage with the community as much as they can. This happened at the same time we were developing our guidance, and they happened to create a dyadic name, which is great, very similar, but this is a group of individuals that are part of the neurofibromatosis type 2 foundations. You can see it's an international consensus group for the diagnostic criteria. They had several different, like the Children's Tumor Foundation, patient advocacy groups implemented here, and they decided to update the name of neurofibromatosis type 2 to NF2 related schwannomatosis. And of course, we go back to that MED12 example we went through earlier. What do you do when you lump these? And this is exactly how you would see this on ClinGen website. Anytime you see these crosshatches, meaning we're deciding to lump or split, you can come see the information, and it will show you that all of those different phenotypes are included, and that this group in ClinGen decided that our preferred name or ClinGen label was MED12 related intellectual disability syndrome. And I'm sure that Sabrina will give you an update of how they've worked this in Mondo later. You also can see what we've excluded out of that, which is Hardaker syndrome. Again, these are lumped, and you can see the rationale that we gave through that lumping and splitting guidance, as well as any notes that we want people to understand why we decided to lump or split. And so this is a great way for us to be able to continue to work with Mondo and to be able to show when we have differences from other resources that are cataloging gene-disease relationships. Another really key point to all of this is that we are using those classifications again, right? And that inclusion and exclusion of data. And basically our limited classification says there's limited data to suggest this gene is related to this disease. And certainly for disputed and refuted, we're telling you it absolutely is not. So there should not be a gene name in these names at all. So part of the process we have to work on is sometimes we have to do the curation first and come back and then propose a name, because we may not know going into it whether or not it meets our criteria to even get to the dyadic naming approach. And so this is another kind of example of where we wanted to give some guidance to not confuse the community by giving a gene name before the evidence actually supported it. And what do you do when you have a limited, disputed, or refuted gene-disease relationship, right? That's the next question. If you can't use a dyad, what are you going to use at all? And so this is where, again, Mondo really helped us, and why using it for ClinGen was so beneficial is because they allow what they call a phenotypic series. When we know that there is heterogeneity present, and we know that there are multiple genes that cause the same phenotype and they look indistinguishable without a genetic test, then we can create a series, much like we see here in inherited retinal dystrophy. Not only does that help us, you know, as ClinGen to come as experts and help update Mondo to go, oh, this should be under this, you know, phenotypic series. This should not be, this should be under something different. But when we have those limited, disputed, and refuted, we could use something broader that is not dyadic in order to give those classifications for our gene disease validity, until which time they meet to a moderate, strong, or definitive, and we can come in and give it a more dyadic name, whether explicit or implicit. And so you might ask, well, what happens when there are multiple names that have been proposed out in literature and reviews and society and anywhere? And so this is an example here where we have ADNP. And so really our key point is that a monogenic disease is a unitary and distinct entity. So it should be represented by an identifier, and it could have several names. And so our issue here is obtaining agreement on one name can be difficult. And so some of our solutions are the ability to cross-reference descriptions like synonyms with unique identifiers. So in this situation, Mondo has one name, OMIM has a completely different one. Now we have gene reviews, and we'd absolutely say, do not call it related disorder. This tells us nothing. And that was never the intent of gene reviews. This says that there are multiple phenotypes they consider in the same disease, and they're going to, or just not in the same disease. There are several phenotypes or disorders related to this gene. They're not talking anything about lumping and splitting. So definitely don't just call it disorder. Have to give it a description. But ClinGen may decide to pick one, the other, or make up its new one. And that's the great part, again, that we have this Mondo ID, and it will link to OMIM's MIM ID with a different name. It's a different synonym. And so another part is, what do we do when there's categorical distinctions diagnostically that might be important, like you can see with IDUA and mucopolysaccharidosis. And so in these situations for ClinGen, we tend to lump them. They are part of a phenotypic spectrum, and we do appreciate that having either one of these does talk about those allelic requirements. So usually it is one of them has two missense. One is a missense and a nonsense in trans. The other one's two nonsense in trans. And we can see the activity shifts and changes, which means phenotypic features become more severe with less activity. But they still represent the same mechanism and the same disease entity. And so that's where we would indicate calling it type 1 and lumping those all together. And also, one of the other things is when we do get to situations where we have to split, there really are mechanistic differences to suggest loss of function, gain of function, or we just don't know, it's an assertion that becomes limited. We would suggest that even if you have a dyadic name, that they should reflect the disease entity and make sure it's not confusing and are actually distinct. So you can see here, BTK has this A-gamma globulinemia, but it also has this growth hormone. This one is the split to dispute. So we used the term by the authors. That is appropriate, right? It isn't necessarily linked to a gene versus now we're using a BTK-related A-gamma globulinemia. The same we can see down here for ApoB. They have distinct phenotypic parts of their name. All right, and so again, why is this all important? Well, I hope you've learned by the end of this is because the curated gene disease validity classification, right, at this part really does set the stage. It is going to directly affect variant curations. Whatever we are curating and lumping means those same phenotypes can be lumped for variant. That means any variant that is observed across all of those phenotypes can now be looked at together, be able to be assessed for their strength of evidence, and ultimately help with that final classification of pathogenic, disease-causing, or benign, and all of the spectrum in between of those classifications. It also is going to help influence dosage where appropriate, as well as actionability. We want to make sure that we have a consistent representation of our Mondo IDs across all of our curation activities. And not only that, ClinGen publishes our gene disease validity classifications to GenCC. So being able to have our lumping and splitting and pre-curation can help to users of GenCC understand why there may be differences in our classification if someone has split where we have actually lumped, and it can help them resolve whether or not there are updates that need to occur across their other resources. And again, ultimately for variant, we're publishing ClinVar into the public. So we want to be very clear about what is included and excluded. So that disease name is really helping to define what that curated disease entity is. And so here's just a few examples that I can show you, but we've certainly had numerous ones, and they continue to grow with Mondo, of where we've had some renaming activities. And our hereditary cancer GSEP, they have really gone through a huge process to be able to rename. You can see they're using an explicit approach, and they want to come to cancer predisposition instead of necessarily a susceptibility to, etc. They felt that as a community, this was something that they were moving to, and they wanted it represented. And the interstitial lung disease, they've been doing an approach, and they're continuing to look at these telomere biology syndromes and disorders. And so again, how they can be able to indicate very transparently about their lump and split and these different disease names. Our general GSEP actually went through an approach with the hemoglobinopathy VSEP because they needed to curate for HbA1 and HbA2, and we felt we really not only needed to work on the naming, but we needed to work on the reorganization of this actual architecture and the ontology. And so we worked very well to even make monogenic and digenic forms of this. We've come up with new names. So this really tested our process on a dyadic name if you're using it with 2 genes and how we would approach that naming. And then lastly, we have the lysosomal diseases GSEP here, again, where you can look where they have lumped. They're all child terms to this more broader general term we've used for our curated disease entity, and that it uses an explicit name. And so all of our guidance can be found on clinicalgenome.org. You can go to our webpage, and usually on the front, you have the monogenic disease naming guidance. You can also go to our different websites. And as in true fashion, I told you we started off as the lumping and splitting working group and the disease naming. And so we lumped those together and we renamed ourselves to the curated disease entity. And so just a roundabout, we can see even in this process how we lumped and split our own groups and change our names. But hopefully with our IDs that we have for our affiliations, we're keeping those the same, and certainly we're helping to redirect as well. But you can always visit the curated disease entity. We're very happy to have expanded this group. We have a technical team, we have a consulting team, and we have a strategic team now. And we are all working together to look over to make sure that we're reviewing curations on ClinGen for consistency, and that we're building our systems and tools to help us better enhance the transparency of this process, and also work with entities like Mondo so that we can be able to submit that information in a more efficient and high throughput manner. And so I just want to thank all of the expert panels that worked with us as we built the guidance. And certainly I want to thank the Mondo team. You all have been fantastic working with us and helping us to understand ontologies, educating us, and knowing how we can work through this, as well as the OMIM team that has also supported us as we begin to think about those curated disease entities and harmonization.
Thank you, Courtney. That was fantastic. Before I go into what it means from the Mondo perspective and how we address all of those requests and changes, do we have any questions for Courtney? We can have a few minutes of questions now. All right. Well, thank you, Courtney. Don't go anywhere because there might be questions coming up. So let me briefly tell you. So you heard Courtney's explanation and the reasons behind a lumping or splitting or how to name a disease. So I want to show you on this side, on the side of Mondo, what we do about that information and how we address those requests. So, as we all know, and as Courtney showed, we work with many different communities. All those communities have a different approach to how to name disease and whether or not to split or lump. And it's really nobody is right, nobody is wrong. It's just that everybody has a different perspective and everybody has a goal and very specific needs. So what we do in Mondo, our philosophy is that we really aim to serve all the communities that have disease information or need disease standardization. So we decided that we're not going to be the arbitrator of what is correct, what is not correct, what how a disease should be named or how a disease should be represented. Because, as I said, everybody has a specific need for Mondo. So we try to represent all the views possible. And of course, we do that not however we want, but we first need to make sure that there's evidence that these changes are correct or true. So if tomorrow I want to rename a disease, Sabrina's least favorite disease, this is not going to happen because nobody else in the world would call it this way. We also need to make sure that the ontology rules are correct. So we are not going to make changes or updates that would break any of the ontology rules. This is the one place where we are not going to be flexible at all. We need to follow ontology rules. And of course, we're going to try to represent all the views to the best of our abilities. As always, those exceptions that are really difficult to represent. So the first example I'm going to tell you about is the lumping and splitting. As Courtney showed, some groups prefer splitting, some groups prefer lumping. And this is the example that Courtney showed about the gene disease related to the MED12 gene, where the ClinGen team is looking at this as the disease as needing to be lumped, while in OMEM's perspective is that this disease needs to be split. So what we do in Mondo, as I said, we're neither gonna split and we're neither gonna lump. We're gonna be doing both of them and none of them. Make up your own word, however you want to call whatever we do. This is we basically trying to represent both of them. And the way we represent both the lump term and the split terms is by making sure they're connected with each other in the ontology. So in this example of MED12, we have a higher level term that is the lump term, MED12 related intellectual disability syndrome. And as ontological children or subclass of this more general term, we will have all the individual diseases or terms. So you have the split terms here, and if you are in a community where you think of this disease as this is my disease entity that I want to annotate to, then you can use this term. If you are in a community where you want to need to make the distinction between those three diseases, then you can use any of those terms. So in Mondo, you will find all the split term, all the split term, and the lump term. And this is fine because if we think of the ultimate goal being that you will have annotations done to the lump term and annotations done to the split term, thanks to the ontology, all of those data and all of those annotations will be related to each other, and then this will help with data integration. So again, there's no good or bad or correct or incorrect way of doing it. We're just giving solutions so that it helps everybody. The second part I want to talk about is the disease naming. As we said, every community has the quote unquote favorite way of calling a disease, and that makes sense if you are coming from a clinician perspective. For example, all you see first is the phenotypes and the symptoms. So the disease name that you can think about is going to be related to the symptoms that you see. If you're a geneticist, it would make more sense to think of a disease based on a gene. So again, nobody is fully correct or incorrect in this way. So what we do in Mondo is that all the diseases named that exist and that are reported to us are added as synonym in Mondo. This is a screenshot from the OLS website. So we do have an official label. This official label is usually the label from OMEM, and the reason it is like this is because our workflow, we have very specific workflow working with OMEM. So the first time this term is going to arrive in the ontology, it's going to most likely comes from OMEM. So that's why the official term is usually from OMEM. If we have a new term requested by another community, for example, ClinGen, that official label would probably be whatever ClinGen team asked for us. We had the example that Courtney mentioned about the schwannomatosis. We had a request from this community who met and all the experts met together, came to a consensus, and asked us to change the official name for that disease. So we did that because there was evidence that there was a whole community that met and made that decision. that being said, all the names of all the disease, all the names that has been used and changed are in Mondo as exact synonym, because if you're looking for information in the literature and you need to go back, I don't know, 20 years, you want to make sure you will find your disease name. So it's a long it's a long and winded way to say, if there's a name, it should be in Mondo as a synonym. And in addition, we add the provenance on of the synonym. So if you go on OLS and you click on this little eye information icon, you will know where that synonym came from or where that name comes from. And we also have, in addition to other databases, we also have some tags that indicate what is the preferred name for specific community. In this case, I'm showing you the preferred name, or the name that ClinGen uses to refer to a specific disease. But we could have those tags for any community who wants to see who wants to indicate which disease name they want to see for the community. And so what it means is that going from there, there's a lot of things that we can do. Number one, when ClinGen takes use Mondo, they can identify which name is the preferred name. And we can, on our side of things, on the Mondo side of things, we can create subset so that ClinGen could, for example, take a version of Mondo that is exactly the same as the version of Mondo, but we can update those labels to use whatever name is the name of interest. So in this case, we had the synonyms that was tagged as ClinGen label. In the ClinGen subset of Mondo, this synonym would become the term label. And because we don't lose track of anything, we would also make sure that the original name, the original Mondo label would be added as a synonym and tagged as Mondo official label. So that will help any community. If you are in a community and you have your preferred, I call it preferred name, it's easier to say. But if there's a very specific ways that you want to refer to a disease, you could work with us and basically tell us, please tag the synonym as the label that I want for that disease, and we can easily create a version of Mondo where that label is whatever name you prefer. I will say that again and again and again. When you do annotations, it really doesn't matter what name you're using. As long as you're referring to the Mondo ID, we will always know that you're referring to this specific disease. So I know that it's probably, if you probably have heard me said that a million times, but this is why working with identifiers and name is, and not name is the way to go. And just to push that Mondo ClinGen subset or specific subset for specific communities, we can also create a version of the ontology where you, as I said, you see the name that you want, the disease name that you want to see, but then also you could say, I don't really care about non-human animal diseases because I'm not working with that. So we could also make sure that in this subset, we do not include non-human diseases. So if you are in part of a community like ClinGen, where you would like to see specific disease name and maybe also only part of the ontology, please contact us and work with us. We can make that happen. And behind the scene, as I said, nothing is different. So the ontology is still the same. All the information in the ontology is the same. The classification is the same. So it's really just adapted to what you need. So this is pretty much it. again, we try to please everybody, and we try to make it so that Mondo is useful to all of you and everyone, as long as the ontology rules are maintained. And again, it means that we need you, our community, not only to help us keep the ontology up to date and the information correct, but then also we need you to bring the perspective of your own community. And that is not only making sure that the disease name that is appropriate from your perspective in the ontology, but then also we can help you use Mondo in a way that is easier for you. So that was the Mondo perspective of the lumping and splitting. I see these things in the chat. So if anybody has a question for Courtney or myself, please unmute or wave your hand up.
I think Megan had a nice question. She said, not to throw a wrench in the nice Med12 related ID example, but what do we do when Orphanet has a different grouping of OMIM record than ClinGen? If the ORPHA grouping is in conflict, is that the rationale to exclude that one term from Mondo?
This is a very good question, Megan. So we are not, let me rephrase. So if the Orphanet name, the Orphanet term is actually a disease, we are not going to exclude that. The only thing we might exclude from Orphanet would be what they call the disease grouping term. So it would be very often something along the lines of neurological diseases with this other symptoms. So this is more grouping term. But if there is like a disorder, disease or disorder that Orphanet creates, and they decided this is the disease, and then it has 5 different OMM and it's different, then what we will do is have this Orphanet term and then create and make those 5 OMM terms children, ontological children of this Orphanet term. It's sometimes a little bit messy, but it was because, and we make sure to indicate that Orphanet is the one that said, this is the Orphanet terms, these are the 5 OMM children. I know that we have a few examples currently in Mondo, and we're working on this. We have a few examples where we obsoleted that Orphanet term because we did not realize, we thought they were disease grouping terms, and well, Orphanet actually thought they were disease terms. So we are updating the ontology to bring back those terms because that was a mistake on our side. But same thing, we take whatever Orphanet has and we show in the ontology what Orphanet thinks. So if it is, let's say, different from ClinGen, you might see a ClinGen lump term and with the split terms as children, and you would have next to it an Orphanet term, lump term in whatever or ontological children are underneath it.
And I think too, I'd love to be able to know also if Orphanet has updated, right? Because we have a date and it's timestamp. This is when we evaluated this. But certainly if you all have evaluated it more recently and there's other data, bringing that to the ClinGen groups can be really helpful because we are not opposed. We are actually want to be able to reevaluate. So if that's something where even we need to reevaluate, right, about our lumping and splitting to see, maybe you have new evidence to suggest something needs to be split out, or again, that Hardikar syndrome came in later. Maybe you've lumped it and we just haven't done that yet. Those are things where just contacting our expert panel or letting them know, hey, we've done a different lumping and splitting and would you consider reevaluating, and here's our data. They'll usually put that on their list of things to work on. But I agree, as you said, if we are ever just totally different and we look at it differently, then it sounds like Sabrina and Mondo have a way to be able to reflect both the differences in how we look at things based on our lumping and splitting.
Yeah, thank you for that answer. Just, yeah, the multiple parentage sort of flexibility within the ontology, I guess, really helps. But, from the view of MedGen, trying to represent all these different groups and all these different use cases, it's like, okay, how many parents can one OMIM record have? As many as
Yeah.
needed, apparently.
Yes, exactly. I think this is
Yeah.
the answer, as many as needed. Melissa, you have your hand up.
Yeah, I just wanted to make an additional comment too. I think it's a wonderful question, and I think maybe as a community we could brainstorm how to communicate this a little bit better. But in the end, some of those decisions are made not just based upon sort of these lumping and splitting guidelines, but also on the ontological structure for the equivalency determination from a variety of different terms that are found in the vicinity in the Mondo hierarchy, and looking across those different resources. And so if it ends up being that way, it's not only sort of clinically and scientifically that we might exclude it, but also for those other reasons. And that's actually one of the best justifications, because it sort of demonstrates that based on, we're really bootstrapping the structure based upon learnings essentially from many other terminologies. And not to say that any one is right or wrong, but when you see a bit more, when we're resolving those inconsistencies, it's usually based upon, an outlier. And so I just wonder if we might think about how to communicate or document that better. We do send that information back to the sources, but then of course they don't always agree or necessarily have the resources to change things or et cetera. So maybe that's helpful too.
Thank you, Melissa. We're past the time, so I don't want to keep you any longer, but thank you so much for being here. If you're watching the recording, thank you for watching. If you have any questions, as always, please reach out to any of the Mondo team or Courtney directly, or to us, and we can put you in touch with Courtney, whatever needs to happen. We have a call on June 27th. So please come, tell your friends, and thank you for being here, and have a lovely weekend. And thank you again, Courtney.
Oh, thank you all.